evening, everybody. My name is Patrick Little, and I'm the president of the European Migraine and Headache Alliance, which is an organization that supports over 30 migraine and headache patient organizations across Europe. I'm also CEO of the Migraine Association, who are hosting this event along with EMHA tonight. Tonight's event is one in a series of these events that have taken place right across Europe and which are supported by an educational grant from Eli Lilly Foundation. So welcome to everyone who signed in for the event, not just from Ireland, but I know there are people tuned in from other parts of Europe. As everybody knows, the world changed overnight in March as COVID-19 swept across the world. In Ireland, as probably in many other countries, access to specialist headache centres almost ceased overnight as hospital staff were drafted into the front line to cope with the huge demands caused by the pandemic. Indeed, even access to primary care services became almost impossible for people. Almost overnight, the Migraine Association of Ireland saw a huge increase in demand from our advice line as stress levels dramatically increased and people became concerned about the impact of COVID on their medication and even concerns about having access to their medications during this pandemic. Many people living with migraine came under financial stress as they lost their jobs overnight or had reduced income as their jobs were furloughed. In many respects, the data suggests that those living with migraine and other headache disorders may have been disproportionately impacted by the additional burden brought on by the pandemic. As part of Migraine Awareness Week this year, the Migraine Association, supported by a grant from Novartis, carried out a survey in Ireland to try and capture the impact of COVID on people with migraine. The main headline findings from this were that 58% of people were getting more frequent headaches. 84% of these cited COVID-related stress as a cause of their headaches. So changes in routine, lack of sleep, increased screen time, etc. 69% of people reported more severe symptoms since the pandemic started. Almost 50% of people reported reduced access to help, and over 50% had appointments cancelled at specialist clinics. As the second wave of COVID has arrived, and we in Ireland are now in our second total lockdown, it's very appropriate that we should have this event here tonight, focusing on COVID and migraine. At the end, we're going to have a presentation shortly from Dr. Eddie O'Sullivan, whom I'll introduce. And at the end of that, we'll have 10 minutes for questions. We asked people beforehand to send in questions, and there's a question and answer button and a chat button that I'll keep an eye on. If we don't get to everybody's questions and you're desperate to get something answered, the Migraine Association has an info@migraine.ie site where you can send your questions in, and we'll get back to people in the future. We also have an excellent website, www.migraine.ie, where people can look at, and it's very comprehensive, so they could maybe start there. Finally, if you haven't already done so, I'd encourage you to join the European Migraine and Headache Alliance Migraine Movement on migrainemovement.com. And people, if you go in there, you'll see what we're trying to do and how we're trying to move the migraine movement forward. When this event is finished, you can watch it again on YouTube, on the YouTube channel, and we'll be publicizing that on our website. So without any further ado now, I'd like to introduce our main speaker tonight, Dr. Eddie O'Sullivan. Eddie is the clinical director of the Cork University Hospital Migraine Clinic since its inception, and is also medical advisor to MAI, and it is indeed recognized internationally for his headache expertise. So Eddie, over to you.
Yeah, okay, well, thanks very much to the European Headache and Migraine Alliance Association, and thanks, Pat, for the introduction. I'm going to talk about two issues in relation to this evening's talk. One is migraine and COVID, and just touch on actually also the issue around headache and COVID-19 itself. So in terms of migraine, we're all familiar with, the categorization of migraine. The main forms of it will be migraine with aura, migraine without aura, and now chronic migraine, of which a number of patients who suffer from migraine will progress to. The key symptoms in terms of migraine attacks, again, about 20-30% of migraine patients will get your typical visual aura symptom, and what you're looking at here is what we call a scintillating scotoma, which is basically a dot in the patient's visual field that it gets bigger over time, 5, 10, 15 minutes. It has a jagged outline, horseshoe shaped, and blurred vision inside the horseshoe. That lasts for about 15, 20 minutes, up to an hour, and then patients typically will get a headache following this. Now, the migraine attacks, and this would be the headache and the associated symptoms. This is the, as again, many of you will be familiar with, is the International Headache Society's guidelines in terms of diagnosis of migraine, and we tend to use that universally across the world, whether you live in Ireland or whether you live in Europe or the United States. We tend to use the same diagnostic criteria, which then gives a uniform approach in terms of all the issues around migraine. So in terms of migraine itself, it's a recurrent headache disorder. Patients need to have at least 5 attacks. They last about 4 to 72 hours. Typical attacks will be unilateral headaches, but not always. They can be bilateral. They're pulsating. Patients will score them quite highly. They're moderate to severe in intensity, aggravated by movement, accompanied by nausea, with or without vomiting, and intolerance to light and sound. So these are the clinical parameters which we tease out in histories and focus on in terms of making the diagnosis and the impact, of course, these symptoms have on the individual. Chronic migraine then is a concept that's been developed quite a lot in recent years, and it reflects about 10% of patients who go on to develop this. And chronic migraine refers to the number of headache days you have per month, and it's more than 15 headache days, of which half of them then are similar to the kind of typical episodic migraine attack, which I showed you on the previous slide, and this has been ongoing for at least 3 months. Now, in terms of trigger factors for migraine, we always take a look at these. I think they're overemphasized, the trigger factors, but they are recognizable in about 30% of patients who have triggers during attack for any individual attack. And then the common ones would be the dietary ones, which because cheese, chocolate, food additives, monosodium glutamate, alcohol, stress, missed meals, overtiredness, menstrual cycle, strong odors, environmental factors. So there's a long list in terms of trigger factors in patients who suffer from migraine, and we always explore the existence of those in patients' histories. However, I think what has become important in the COVID pandemic is the influence that trigger factors and lifestyle triggers have had on the individual. And a lot of these, I think, are certainly around stress issues, and I would categorize stress into different forms. Stress is whatever it is for the individual. But I think clearly, first of all, I would say generalized stress. I mean, I think in the pandemic, individually are concerned about the potential of getting this virus ourselves. If not ourselves, maybe some member in our family might get the virus, or we've got elderly relatives, parents, friends. So there's this general concern and stress about, the devastating nature of this illness for many patients. And that in itself is a worry for individuals. And then there's the stress, individual stress, I think, because all of our work lives have changed for many of us as a result of the pandemic. I think working from home is a good thing for some, but it creates an awful lot of stress in its own way, in the terms of many individuals have to multitask, in the sense that you could be living and working at home. There could be other members of the family around you, or for example, with women who've got young children, they may have to multitask in terms of looking, because they may also be, in terms of lockdown, other family members in the house, and you're trying to continue your work and also at the same time look after children or look after other people in the house. And that in itself is undoubtedly a source of additional stress and a new form of kind of trying to time manage your days compared to the pre-COVID scenario. Other aspects of it, it's well recognized, domestic stress. I mean, there's a lot of tension within families. who have to stay together under the one roof day in, day out, and it leads to domestic violence, not just physical, but also verbal. And that in itself, will undoubtedly make one vulnerable to your threshold for migraine. Again, sleep patterns are disrupted. And again, a very important aspect of this is lack of social contact. I mean, I know people have praised the concept of being able to work from home because it improves their time management. But I think what people forget is that there's a huge amount of social contact in your day-to-day working routine. If you're working in a factory or a hospital or a bank, and you meet lots of people in a very casual nature, which you simply having a chat about something or other when you're having a cup of coffee or buying the newspaper. I think as individuals, we're not wired to be living in an isolated environment and working from home. And I think that undoubtedly as well is a big influence on threshold for migraine. Lack of exercise is an important issue. Many people who are working from home, it's probably due to the nature of the job. Obviously, if you work in the IT or if you're working in things like insurance company, an awful lot of this can be done on the computer from home. And again, that leads to all the stress issues that I talked about, but also social isolation, excessive amount of time on the computer, and inactivity. And of course, behind all of that, then, irrespective of the stress that one has experienced as a consequence of COVID, patients with migraine, some of these patients will have comorbid anxiety and depressive states independent of COVID, and these will be enhanced or become to the fore even more because of the additional stresses during the COVID time. So I think these trigger factors undoubtedly have had a big impact on migraine sufferers over the past 10 months. So there was an important and interesting article looking at this concept of what's been happening to migraine patients during COVID-19. And this is an article that was published recently in the Journal of Headache and Pain. And this was a survey that 1,000 patients self-administered. 84% of the patients were female, 71 were aged between 20 and 40, 61% of them are married, and 46% have continued to work during the pandemic. Now, what this survey identified is that 60% of these patients had an increase in the frequency of their migraine attacks during the COVID period. 10%, which is a big number, progressed to chronic migraine, which is the more than 15 headache days per month. And 64% outlined an increase in the severity of the attacks when they occurred. So as you can see from this slide below, a huge impact for what the patients who filled this survey had in terms of their migraine during COVID compared to pre-COVID. In contrast, and I suppose it is worth observing, that about 16% of the respondents actually felt that their migraine improved during the COVID period. And that may well be due to the fact that because if they're working from home, it brought a certain amount of efficiencies to their time management, and the long commute, in the morning and the evenings, saved a lot of time during the day, and many found that very helpful. So there is a group who felt that their migraine has actually improved during the pandemic. However, previous slide, that's not the case for the majority. The majority have had an increased frequency and severity of attacks during COVID-19. Now, in terms of how do they manage their migraine, 46% of the patients said they continued with the recommendations that they had pre-COVID. But again, importantly, upwards of in excess of half reported that they started to overuse their acute therapies. Again, most of them didn't consult doctors. Maybe that's because they had lack of access to them. And again, of course, the non-drug treatments such as Botox injections, physiotherapy, acupuncture, they had lack of access to these treatments during COVID because of the obvious risks associated with administering these treatments during the COVID pandemic. 4% of these patients who were surveyed actually did get COVID-19 during during the survey period, and they noticed that when they did have the COVID-19 out there, they had a worsening of their headaches if they had COVID. So, and again, there were other factors in terms of most patients described a lot of sleep disturbance as a consequence of COVID. And again, that could be around the issues of anxiety and stress as well. And of course, in terms of those who had premorbid symptoms of anxiety and depression, these tended to worsen, have also worsened during the COVID period. So clearly, the big takeaway message from this survey is that COVID-19 has had a negative impact on the majority of patients who suffer from migraine. So how do you advise, or what would be my advice in terms of managing or giving advice to migraine? Well, the migraine hasn't changed in the sense you suffered from migraine pre-COVID. It's just it's become much more problematic for many patients during the pandemic. And I think the obvious reason and the reason that explain this is all the issues around the triggers and stress and change of lifestyle and disruption to routines that is a consequence of COVID. So my advice in particular, starting out apart from any medication aspects of it, is to be vigilant regarding trigger factors and potential trigger factors that occur, particularly the management of stress. It's important that when you've got a new structure to your days, that you keep to regular routines, plan it well, take regular breaks, avoid missing meals, have a good breakfast, try to keep to a healthy sleep routine at night time. And I highlight regular exercise. I think exercise is of huge importance and benefit therapeutically, both from a mental health point of view, but also as a preventative measure in terms of reducing the frequency of which migraine can occur. So I think particularly if you're cocooned, as they say, for long periods during the day and during the working week, I think it's important to take regular exercise on a daily basis. And it's not just the exercise itself that's good for you, but just getting out into the fresh air and moving around, and then even interacting with people casually while you're out in terms of increased social contact. Also, I recommend to be careful with alcohol. It's well recognized that alcohol consumption has gone up during COVID, and the pattern of drinking has changed quite a lot during COVID, and any of us at the end of each day, if you've been, cocooned in one part of the house, that you reach a certain time of the day and it's time to have a glass of wine or a glass of beer, and that pattern of behavior has certainly been increasing during the COVID period. And of course, there's obvious dangers with that in terms of migraine and they either triggering migraine attacks or worsening existing migraine attacks. So be careful with those. So having good structures and vigilant on your trigger factors by keeping a good diary, I think is the most important way forward initially, without addressing any specific medication issues. Having said that, though, these are traditional treatment options for migraine. On the left, you have the acute therapies, and whatever works. Obviously, patients are well experienced in terms of trying to manage their migraine, but you always need to review with your headache diaries how effective by managing any individual attack and which is the most suitable acute therapy for any individual attack, whether it's a simple analgesic such as paracetamol or a more specific migraine drug such as sumatriptan or zolmitriptan, or alternatively things like the NSAIDs such as diclofenac and naproxen, and the addition then of anti-nausea agents. It's important to remember that you should not use acute therapies more than 2 to 3 days per week because of the risk of getting medication overuse headache. And we did see in that study that I outlined that a lot of these, over half the patients were starting to overuse medications, and 10% of that study group went on to develop chronic migraine. So you need to look at your approach to the management, and this is where preventative drugs are very important if patients haven't been on them, that they need to be introduced. Particularly, they should be considered in anybody who presents with more than 4 headache days per month. And whether it's a beta blocker or topiramate or Ibuprofen or flunarizine or botulinum toxin, they need to be considered. Also, if patients are on a preventative drug and they feel it's no longer working, then they need to be considered for an alternative preventative drug. And of course, then just in terms of putting it all together, in terms of the review, headache diaries, as I said, identifying, avoiding, and being vigilant around trigger factors. Review your acute drugs if you're not managing as effectively as you were previously. Review preventative drugs, particularly if you've never been on one and your headache frequency has gone up. If you're on a preventative drug and it's no longer working, an alternative one. Obviously, the opportunity to consult a GP or neurologist is important. Obviously, there's a lot of new ways of consulting now too, in terms of this platform, in terms of video consultations, etc. Now, again, just to highlight the risks of migraine management, as I said, 10% of the study group went on to had developed chronic migraine during the COVID-19 period between March and now. And that's defined as more than 15 headache days per month and has been present for more than 3 months. And they've also got a risk of medication overuse. So many of these patients would then certainly need to be considered and would be suitable candidates for the newer drug treatments which are available, the Monotonal antibodies, which are what we call CGRP antibody antagonists, and they're very specific for migraine. There's a lot of excitement around these medications because they do help or do appear to be even better than what the clinical trials have been showing. And this is just a side to demonstrate the efficacy of these particular drugs. And what you're looking at in the top line would be the placebo, and the bottom lines would be the active drug. And you see that there's a divergence between the placebo and the active drugs quite quickly, even within a week or two of starting these medications. So brings about a marked reduction in the number of headache days and migraine days that patients get. So again, patients who go on to develop chronic migraine, and we did see those occurring in the study, they would be candidates for exploring these kind of optional treatments with their doctors. So the conclusions in terms of migraine and COVID-19 is that COVID-19 has had an overall negative impact on patients with migraine. Quality of care measures need to be monitored with special emphasis on the psychosocial measures and stress management. So that's all I want to say about migraine and COVID, and I just have 1 or 2 slides just to talk about headache and the virus itself. It's been demonstrated in an important study that was presented in the American Headache Society in the summertime that 10% of patients with COVID-19 viral infection present with headache and loss of smell. And it tends to invade through the nose and what we call the nasopharynx and through the trigeminal nerve, which is the pathway for pain and headache. And it's an early symptom in about 10% of patients without the triad of what we're always being told about to look out for, which is the cough, the shortness of breath, and the fever. So headache is Having said that, if patients with COVID-19 present with headache alone, it tends to be quite a good prognostic indicator in terms of how the patient will do. It tends to be a short duration, and patients have relatively low short stay inpatient duration length. So it's a good indicator. However, a headache can persist, and it's more common in women. It tends to be more of an ordinary type headache, and that's a bilateral frontal headache. Many of these patients will have a past history of migraine, but some will have no past history of migraine. But it tends to occur in younger patients, and the problem is, though, many of these patients had daily headache persisting for 6 weeks after the infection. So the implication was that a lot of these patients were going to go on to develop what we call new daily persistent headache, which can be a problem in its own right and an entity in itself. And it appears that COVID-19 would well be one of those triggers for those patients who get a new daily persistent headache. And I think hopefully I've completed the presentation on time. Thank you very much.
Okay, thank you very much, Eddie. There are a couple of questions, Eddie, just before we finish. Are you aware of any contraindications with migraine treatment in terms of people being treated for COVID? So are there issues if you have migraine? Are you more susceptible? The other main question here is about can CGRPs affect my immune system? And will I be more at risk of getting seriously ill if I catch COVID on these days? these drugs?
CGRP monoclonal antibodies do not affect the immune system. It's not like other monoclonal antibodies for other conditions that are suppress the immune system and patients at risk of infection. The CGRP monoclonal antibodies do not suppress the immune system. They're actually broken down in the bloodstream itself. So there are no risks attached to the CGRP monoclonal antibodies and the risk of getting COVID or any other type of infection due to immunosuppression. It doesn't cause immunosuppression.
Okay. And somebody else has asked, I take ibuprofen for my migraine. Should I continue to take this?
It all comes down to the efficacy. I mean, that's why we get patients to keep diaries. You know, whether you take ibuprofen or any other thing, it's safe to take a medication. Yes, there was an issue. In the early days, we call them urban myths that NSAIDs put patients at risk of getting COVID-19. Not the case, not true, and that has been, you know, that question has come up early on back in March, April, but there's no evidence at all to suggest that there's any problems with ibuprofen and taking it for not just migraine, but for other conditions for which the ibuprofen is indicated for.
Okay, that's good, because that did come up with us as well. Another question, Eddie. I've had great success with Sibelium and Naravirk over the past 3 to 4 years. Is it bad to stay on them long term?
Well, the Sibelium is licensed as a preventative drug, and you take it 5 days a week, and then after 4 months, you're meant to go on a holiday from the drug, as they say, for a month, and then you can restart it. Again, it comes down to how effective you find it as a preventative drug, the goal of which is to reduce the frequency and severity of attacks, and if that's achieving that, then you can remain on it long term. But it's licensed in a different way to other preventative drugs that you take it once a day for 5 days a week, or once or twice a day for 5 days a week for 4 months at a time, and then a drug holiday for a month, and then you can recommence it. And there's no problem taking naratriptan as an acute therapy, but you should always limit the triptans, which is one of those. Limit the triptans to no more than 10 doses per month.
Okay, Eddie, that looks like all the questions at the moment. As I mentioned to people earlier, if you do have any questions that we didn't get to, or if you've got questions afterwards, feel free to send an email to info@migraine.ie. If we don't know the answer, we'll go and check with our medical advisors. There was one person asked quite a specific question tonight that we'd like to be able to deal with, but I think it's better dealt with individually with that person. I suppose just to reiterate some of what Eddie said about giving people the best chance during this period. It's a difficult time for people, as I mentioned earlier. So just reiterating what Eddie said about establishing a daily routine, maybe limiting screen time is one of the things. Practicing some self-care. So doing things to try and keep you well, having a good sleep hygiene, trying to reduce stress, which is again very difficult, but thinking about things like meditation, yoga, mindfulness. The Migraine Association runs seminars online during this period, particularly at trying to address people's stress levels. So we have different types of events. I'd advise people as well to visit your pharmacist as a first line of question. Pharmacists now are very, very knowledgeable and they're available, and maybe more available than a GP, but don't be afraid to go to a GP if you're not, feeling well, if things are not working out for you. And also what Eddie said about keeping a migraine diary is very important in terms of long-term people being able to do an assessment. So finally, I would just again like to draw attention to the Migraine Association's website and the info@migraine.ie, and also the European Migraine and Headache Alliance Migraine Movement that I mentioned earlier. Type in migrainemovement.com and you'll see what we're trying to do. And finally, this event will be on YouTube, and again we'll publicize where you can have access to that. Eddie, someone's just finally asked, can migraine not have a throbbing headache? Can a migraine not have a throbbing headache?
Yeah, that's an important question, actually, because it certainly can do. I think we don't base the migraine diagnosis around just one aspect of the symptoms, but it is obviously what we call a typical throbbing, pounding, pulsating headache. But for many patients, they will just describe it as a severe, constant. It can be dull or pressure, but you then must look at the other symptoms, to make up the migraine attack. Is the headache still one-sided? And even though many patients will describe the headache as being constant and dull, they will still say in lots of occasions that it's aggravated by movement. And the other aspect of it, of course, is that patients will tend to score the headache quite high. I use an analog scale, 0 to 10. And migraine patients will tend to score the headache somewhere between 7 and 9 or 7 and 10. So it can be a non-throbbing headache, but they'll still often score it quite high. And then, of course, you do need to look at them, the other associated symptoms. Is there the presence of nausea or vomiting? Is there the presence of intolerance to light and sound? So sometimes when the headache is throbbing, I suppose it does make the diagnosis easier. Sometimes the diagnosis of migraine can be challenging. And I think that's where you do need to look at the other symptoms in terms of, is the headache one-sided? Is it accompanied by other symptoms such as intolerance to light, sound, and nausea? And is it, of course, if it's preceded by the aura symptoms, such as the flashing lights, the zigzag lines, the scotomas? I think that makes the diagnosis very easy, irrespective. In fact, some patients who have the aura symptoms of a migraine attack often have a headache that's not as debilitating, as the patients who typically complain of the throbbing, pounding headache.
Okay, then there's two more just in, and then we need to stop. I've suffered chronic migraine headache for 6 years, and now I'm taking anchovy injections, and I'm in my 6th month, but I don't feel any improvement. What do you think about anchovy?
Yeah, well, unfortunately, you do appear to be a non-responder, and I think, unfortunately, like any treatment option, not everybody responds. There are other CGRP monoclonal antibodies out there, even though we don't know yet if you don't respond to one CGRP antibody, is it a class effect? They don't all work the same. Anchovy, which is fremanezumab, works on the molecule, whilst aranumab, which is the other available CGRP, works on the receptor sites. So they're not quite the same drug. There is evidence out there now coming through, let's say from international studies, that if you don't respond to one of the CGRP monoclonal antibodies, there's a potential or possibility you could respond to the other one. But I think from the questionnaires perspective, it's disappointing that she hasn't seen a benefit with the anchovy, because in clinical practice, we do see a lot of benefit for many patients with these therapies.
Okay, and the hope is that some of the newer ones then coming online may work, because it's such an individual condition. This is the problem. Okay, and finally,
also,
Eddie.
So I just going to say, also coming down the tracks, a small, but it would be the small molecule CGRP antibodies, which would be, one of those would be for migraine prevention as well. So there will be other options as we go forward, hopefully, which will increase our patients' options.
Okay, and finally, I'm using Imgram for my migraine. I'm taking it very regularly now. Is it safe to be taking it on such a regular basis? And it's the only thing that works to relieve my migraine.
Yeah, well, then this brings us back to the potential and risk of medication overuse headache. And I think when she says regularly, because that could mean anything, but what we would say is that one should limit the use of Imigran as an acute therapy to 10 doses per month, or at max 12. And I think if you're taking it more than that, then you need to use preventative drugs and all the treatment options that there are around prevention. But there is a risk of medication overuse with the triptans, and Imigran would be one of those.
Okay, and there's one final one. Are Lidocaine infusions effective on chronic daily headache and migraine?
They're not done in Ireland. I mean, I think, they're all treatments, okay, and they were done in specialist centres in the UK, where patients with chronic would be given lidocaine infusions. It's not without its risks. You know, lidocaine as a drug given IV. I'm not sure if it's given anymore. It was given in the past. There's very little support in clinical trials. There's no clinical trials on it, but you know, I think there's the personal experience of some experts who have given lidocaine infusions as a treatment, you know, for intractable headache patients, migraine patients, as an inpatient. It would have to be done as an inpatient, but I think it's probably a treatment that would be no longer recommended very much. I think there's, again, there's a newer monoclonal antibody, CGRP, eptinezumab, which will be coming available, particularly in the United States, where that drug is IV, and they're getting some quite remarkable results from this particular drug. So, lidocaine, it was never licensed for use for chronic migraine. People have used it anecdotally, but I think it's probably going way out of fashion.
Okay, we'll need to call it a day because of the time. Thank you everybody for joining us. Thank you to the European Migraine and Headache Alliance and to the Eli Lilly Foundation for organising the event. As I say, keep in contact with us and come back to us if we haven't answered questions. And thanks a million, Eddie, for your presentation. I would just apologise for the sound, but apart from that, everything was really good, Eddie. Thanks very much. Okay, good evening.